Hello, good evening, everyone. Welcome to today's session on the topic Pontics that will be covered under the fixed partial denture. So let's start. I would like to share my screen. Just give me a few minutes. Yes, I think you all are comfortable and my screen is visible to you. My PPTs are visible. So in today's session, we will talk about Pontic and its design in FPD. So, what are all the contents that we're going to cover are the introduction, definition of Pontic, what is Pontic, what are its function, how do we access, what type of Pontic do we be needing, what are the ideal requirements, its classification, considerations in designing a Pontic, followed by conclusion and references. So, coming on to the term Pontic, it is an artificial tooth in a fixed dental processes that replaces a missing natural teeth, restores its function, and usually fills the space that was previously occupied by the clinical crown. This is the GPT-9 definition of a pontic, and it serves as a function that aids in mastication, speech, maintenance of relationships, and as well as aesthetic for the patient. So coming on the pre-treatment assessment, before we need to start designing our fixed partial dentures, it is a Pontic space that is available. Either the adjacent tooth are coming into a Pontic space or any super eruption from the opposite side and how's the residual ridge contour. The residual ridge contour can be classified according to Siebert's in three classes. That is class 1, loss of buccolingual width. Class 2, the loss of height, and class 3 consists loss of width and height at the residual ridge contour. So coming on to the requirements for the ideal Pontic design, we broadly classify them into three parts, that is biological, aesthetic, and mechanical. Biological consists of biologically, it should be cleanizable and should not have any pressure on ridge that causes the blenching. And coming on to aesthetics, it should be as ideal or it should be resembling as same as the natural tooth appears to grow out of edentulous ridges. It should have sufficient space for the porcelain build-up if you are doing a PFM or a all ceramic pontic. And mechanical, it should be rigid, hard enough. It should have a strong connectors. The width should be available and a metal framework to resist any fracture. So coming on to the classification of Pontics, according to Rosenstiel, there are two types. Either it's contacting the mucosa or it's a non-mucosal contact design. In non-mucosal contact design, you have hygienic or a sanitary Pontic, and the other type is a modified hygienic Pontic, when there is no contact between your Pontic and the residual ridge contour. The other type in this classification is the mucosal contact design that includes your ridge lap, modified ridge lap, conical, and ovate type of Pontics. Now, the same Schellenberg author describes it as three types. One is based on the material use, whether it's all metal Pontic, it's a non-metallic Pontic that is your all ceramic, or it's a PFM that is a porcelain fused to metal ceramic. Now, coming on to the manufacturer's design, it can be either a custom made or a prefabricated. The prefabricated ones that are available or not recently used, that were earlier available, were flat back, on tips, or reverse pin facing types. Now, coming on to the main classification, that is more useful for your exam purpose or practical purpose, is the shape of Pontic. It includes ridge lap, that is also called as saddle type of Pontic. It's a modified ridge lap, hygienic, conical, and ovate. So five types are ridge lap, modified ridge lap, hygienic, conical, and ovate. And we're gonna talk about this classification in detail. What are the indications, contraindication, advantage, disadvantage of all type of Pontics into the upcoming slides. Now coming on to the saddle or the ridge slab Pontic type, it's a concave fitting surface that overlaps the residual ridge buccolingually. It stimulates the contours and emergence profile of the missing teeth, and it is not accessible to cleaning with floss. So hygiene is not that much possible in this type of Pontic. I think you guys might appreciate this in the diagram. This is the modified ridge lap of Pontic, where it covers the facial-lingual residual ridge both sides. Coming on to the next, it's a modified ridge lap Pontic. So basically, what they have modified in this is that only the Pontic covers the buccal part of your residual ridge. So it is overlaps the residual ridge on the facial part to achieve the illusion of tooth emerging from the gingiva. So that when you look from the front, it looks like Pontic or the teeth, an artificial teeth that you're giving in FPD resembles to appear coming out of the gingiva. I'm so sorry. Now, on the linguals, the modification, what and how it is different from the normal residual ridge or the saddle type is that it remains clear from the ridge on the lingual sides. So if you can appreciate this same in the diagram, this is the buccal or the facial part, which is the area of contact to the residual ridge. These type of Pontics are usually recommended for replacement in high aesthetic areas, that is anterior teeth, premolars, or the maxillary molars. Coming on to the hygienic Pontic, it is a non-mucosal contact type where the tissue surface of Pontic remains clear of the residual ridge. Its disadvantages include the entrapment of food particles, which may lead to tongue habits that may annoy the patient. That constantly nagging or discomfort to let that food escape out can cause some tongue habits to the patient. It is usually advised for the replacement of mandible molars, never to give in the aesthetic area. Coming on to the next, that is a conical Pontic, that is a fourth type, is often called as egg-shaped, bullet-shaped, or heart-shaped Pontic as well. These are more easy to clean, and this is how the shape looks like. It's a heart shape or a conical look type where the thinnest part contacts the ridge area. It is usually recommended for the replacement of mandible posterior teeth thin ridge where aesthetic is less concerned. Coming on to the ovate Pontic. Ovate Pontic is the most aesthetically appealing Pontic design. Convex tissue surface resides in a soft tissue depression or hollow in the residual ridge. Appears that tooth is literally emerging from the gingiva. It is the most aesthetically Pontic that is available. It is recommended for use in the region of broad flat ridge of the missing teeth in the areas of high aesthetic requirements. So this is what is the difference between the ovate and the modified ridge lab if you guys are concerned. One second. Yes. So this is your ovate type of Pontic. Now, coming on to the considerations, what are the biological considerations that you have to keep in your mind for designing the Pontic? Pontic is that first is the ridge contact. It should have your Pontic should have a passive contact with the mucosa, with your residual ridge. It should not have active contact, otherwise it might cause the blanching of the tissue, and it should be on the keratinized attached mucosa. It should have as small as the area of contact, and the ridge surface should be convex. Coming on to oral hygiene, patient should be able to easily clean the prosthesis. I should be able to floss or have a rinse so that there is no food entrapment or poor oral hygiene leading to the because of the prosthesis. Coming on to the Pontic material, if you are using a porcelain, it should be a glazed porcelain. That is the best. Polished surfaces holds the most importance in dentistry. If your prosthesis or whatever restoration you're giving is unpolished, there will be more plaque or calculus attachment, and the problems will increase for the patient. There will be more plaque, more bacterial attachment, more decay, and more dental issues. So it should be have a glazed porcelain, highly polished surface, no mucosal contact at the junction of PFM, and the junction of PFM should not lie on the ridge. Your occlusal tubule with buccolingually should be as same as your natural teeth, and it can be narrow if your ridges option is zero. And we have already discussed that you have to decide your Pontic design according to the Seaboot's classification that we have already discussed. Class 1, Class 2, Class 3. Class 1 was the loss of width, Class 2 was the loss of height, and Class 3 includes the loss of height and width. Now, coming on to the mechanical considerations, your occlusal surface should not be narrowed arbitrarily. It can create a food impaction, cheek biting, or tongue issues, or plaque retention. The cusp tip to cusp tip width of posterior pontic should be same width as the original missing teeth. In PFM, it should have a uniform veneer layering of porcelain that should be approximately more than 1.2 mm. The metal surface should be smooth and free of pits. Sharp angles should be rounded, and a substructure matrix of pigmented glass or polymer fiber to provide structural strength that is called as fiber reinforced composite pontic. So, if we consider, first is better because it has a less area of mucosal contact, as well as the layering of the porcelain is uniform. You can see this area, this is less area in this. It is the area of contact to the mucosa is more. In the picture 2 and 3, there is uneven layering of the porcelain. So, according to the pictures, one will be more better, where your veneer layering is even and there is as small as area of mucosal contact with the optic. Now, coming on to the aesthetic considerations, the gingival interface, the modified ridge lap pontic recommended for most anterior situation as it compensates for the lost buccolingual width in the residual ridge by overlapping what remains. A special care must be taken when studying where shadows fall around natural teeth, particularly around the gingival margin. The ovid pontic should be in conjugation with the alveolar preservation or soft tissue rich augmentation. The next is the incisor-gingival length. If you have a too much of incisor-gingival length, then try to consider of giving a pink portion where there is a loss of height of your ridge contour, or you can plan of ridge augmentation procedures, whatever suits. But this will be very aesthetically unpleasing for the patient. So either you do a ridge augmentation procedure where you have to give a bone graft, then a soft tissue graft to get your ridge contour back to the normal height, or else this your pontic should have a pink porcelain that resembles like your gums. Like this, something like this. So coming on to the Measy district, it should incorporate versus perception principles into the Pontic design. It should be ideally as same as the space that is available. So coming on to the conclusion, the most aesthetic design is the ovoid Pontic. Just give me a second. Yes. So coming on to the conclusion, what is the most aesthetically pleasing Pontic? That is ovate. Most hygienic is the hygienic Pontic. Hygienic as well as aesthetic or the most commonly used are the modified ridge lap. Thus, design should allow easy plaque control, minimize tissue contact, and should incorporate the principles of design. These are my references. The recommended books for you are the Rosenstiel and Schellenberg for your fixed partial processes. Thank you so much for giving your time and patience to me. I'm Dr. Nitin Garg. I'm a exhibition prosthodontist. If any doubts, please feel free to contact me anytime, either through mail or WhatsApp. Thank you. Thank you.